talking about some documentation issues, is going to catch a plane to go have some fun in Utah, floating a river with his kids. And then I will be talking about the Travis Act, and then we'll have case reviews as usual. So we'll jump right into Dr. Mock. He's going to talk about documentation, SOAP format, the narrative, and this is a good way to avoid medical legal issues, a good way to avoid the dreaded phone call from the MPD's office asking, can you tell me something about your chart? So, you know, it's worthwhile staying awake for this part.
Thank you. And so thank you to everyone for coming. Obviously, this doesn't pop off the page as the most exciting topic, but this is something that we do every day and something that's relevant to having a long and productive career. We thought that we should take some time. We realized we hadn't put in one place what our expectations are for the documentation, and we thought we owed it to you to be clear about what we're looking for and what the goals are. And so what we're trying to do with the chart is provide something that's clear and concise for clinical care, that both documents what you did and that allows other people in the healthcare team to see what happened in the pre-hospital environment. We want something that's accurate, that we can look to as we try to figure out how to take better care of patients. And then sometimes these cases go to legal action, and we want to have something that, if needed, could be defended in a court. So why are we doing this now? I'm just curious, by a show of hands, who has not had the experience of completing a paper chart as your final documentation? So about 25% of the room. So we've undergone this big shift in the way we deal with health records from this handwritten note to an electronic format. And there are huge advantages that come with the electronic format, but there are big disadvantages as well. And so what we're trying to do here is talk about how to keep the most important parts of what was in the paper documentation and to bring that into the electronic documentation so we have something that works. So the electronic health record is legible. It's easy to send from place to place, and it lets us collect data fairly easily. It can be extraordinarily time consuming. There can be click after click after click, not all of which that gets the key information across. And it doesn't always tell the full story. You end up looking at a lot of these charts. A lot of charts look the same, and you lose some of that specificity of the call. And the reason we're here talking to you about this is that you're all trained, you're experienced, and your view of what happened is really valuable. And so we want to make sure that that doesn't get lost in the electronic chart. And then finally, the electronic chart is good at showing what happened, but it doesn't show what you were thinking. And especially, so both for clinical care and also for medical legal purposes, documenting what was going on in your mind at the time, how you were taking all those facts together and making clinical decisions is really important, because there are many cases that don't end up going the way we thought they would, but your job is not to predict the future perfectly. Your job is to do the best job managing the information that you have in real time. And so there's some unique things about pre-hospital documentation, because I think all of what I've said before is true for what's in the hospital as well. But the things that are really unique about pre-hospital documentation is that you don't have just the patient, but you have the scene. And you are the only health professionals that can describe what the scene was like, whether it's someone who had a major mechanism car crash, who fell off a building, or who lives in a house that's completely unkempt with newspapers falling over everything. that piece of information is really key, and you are the only people who can capture that. Because pre-hospital care is by nature mobile, you've got a limited chance to pass what you're seeing and what you did on to the rest of the healthcare team. You've got a verbal report, and then you're going to be in a different location. Whereas, if I pass someone up to an inpatient doctor, if they have a question, they can come down and talk to me. They can come down and they can come down and see me. We have a chance to talk about it. So you go through this tight pipeline where there's only a small chance to communicate that information. And then you operate under more time pressure than we do in the hospital environment, in that you're trying to get a document out, but then you're also trying to get back in service. I can be seeing one patient, waiting for something else to happen, while I'm finishing my chart, but you finish that one patient, and then you're under pressure to get back in service. So there's a unique set of challenges that go with a pre-hospital record. So we just wanted to make clear what it is that we're looking for and to agree on a standardized format for what we're doing in the county. And so many of you have heard of this before, but we just wanted to recap and put it all in one place. So what we're looking for is a SOAP note: subjective, objective assessment in the plan. So for the subjective, as much as possible, we want to keep the subjective information in the subjective section. So this is what the patient told you, what the family members told you. It is really helpful to have the patient's complaint in their own words. Whether it's something straightforward like chest pain, or I'm cold, or I'm hungry. And then this is your chance to include the pertinent positives and negatives. And this is something that the electronic chart doesn't do a really good job of capturing. But if you're seeing someone with chest pain who doesn't have nausea, doesn't have diaphoresis, those are all really key points. And the subjective information is the key place to get that. So here's an example. I'm going to go ahead and read it out loud. I thought this was an example that we pulled of some really excellent subjective documentation. So, dispatch priority 2 for airplane accident. Arrived to patient lying prone on the ground off to the side of a private airstrip. Patient is in the care of neighbors. Patient states that she was standing on the side of the runway, videoing her husband take off in the plane, and the next thing she knows, she's lying on the ground with her neighbors around her. Neighbors state that they witnessed her standing on the side of the runway, and the plane came down the hill and hit her with a left wingtip. State she was unconscious for approximately 5 minutes, but has been completely alert since she woke up. There are several large pieces of plastic resembling the leading edge of an airplane wing on the ground next to her. So that is highly specific. It gives you all the information that you need to know to think about the mechanism of the call. And there's no chance you're going to confuse this chart with some other chart from a couple of weeks ago. So moving on to the objective, the key points here are that what you see in the initial presentation is really critical. This is another thing that the electronic health record does not do a good job of capturing. So when you walk into, this is your view from the door, and you see the patient ashen, appeared to be near arrest, smiling, interactive, playing with his sister, at the bottom of the stairs covered in stool. Those are all key things that that everyone else in the healthcare team is going to use to understand what is going on in this situation. Anything that can be objectively reassessed is really helpful, because there's always going to be a transition of care, and anything, so it is somewhat helpful to say moderate respiratory distress. Most experienced healthcare providers can have a sense of what that looks like, but anything really specific, 3-word dyspnea, respiratory rate of 40, no radial pulse, those are all things that can be objectively reassessed, and that you can show both through the course of your call and between the pre-hospital setting and the hospital setting what has changed. And in the in the objective, there's usually one system that really needs to be documented well. So, for example, if you're dealing with someone with sudden onset weakness, describing what they can move, what they can feel is really critical. If you're dealing with a patient who has an arrhythmia, say AFib, describing the cardiovascular exam, whether the heartbeat was regular or irregular, what kind of perfusion they had, what their pulses were, those are the key things. And then most of the other things aren't that relevant. Whether the head is atraumatic in someone with an arrhythmia, unless there's a major fault, that's not a big thing. But think about, as you're writing this, what's the key system that I need to document here? So here are some examples. Medic 1622 arrived on scene to find the patient laying in bed. She was conscious, alert, oriented × obvious respiratory distress, appeared lethargic, pale, tachypnic, and could only speak in 1 to 2 word sentences. The patient had several full-thickness lacerations to the forehead with no active bleeding. Anything like that that describes that sense that you get just walking on scene, walking in the door. And that can also be a description of the scene. We arrived and there was a domestic dispute in progress. Those things add that specificity to your call. And when you need to explain, no, I didn't get a pulse ox there because I was in the middle of a domestic dispute. Those things really paint the picture. And both for medical director review and for if there were a legal review, those things are really clear. Because all we're asking is to make the best of the difficult situation that you're in. Pre-hospital care is never going to be perfect, quiet. That's more something for the primary care office. So then moving on to the assessment, we want to hear what you think is going on. Now, there is a place in the electronic health record that you can put your assessment, and that's fine. But what I would put in the back of your head is don't let the computer make you say something that you don't want to say. So if the computer makes you fill in, this is chest pain, fine. But if there's something else that is on your mind, then this is chest pain, considering acute coronary syndrome, or this is chest pain chest pain after a fall. That's blunt chest trauma. We want to know what you're thinking. And then if you made a key decision, this is a STEMI activation, code stroke, sepsis, we want to hear that. And so we're looking for a brief summary, but if there's more that you want to say about what you see going on, that thought process is helpful. And then the plan is a concise summary of what you were planning to do and then what happened. And then if there was an important decision that you made, we want to hear why that happened. So here's an example of the plan. In the short time from the patient's bed to the ambulance, the patient's respiratory drive began to decrease alongside her level of consciousness. Patient was advised of concern over her clinical course due to lack of POLST or DNR forms from facility staff. Patient was asked what limitations she wished for her care. She stated she wanted crews to do everything. Patient's son concurred. IV access obtained, corticosteroids given, CPAP was applied as a last line treatment. Patient did not tolerate CPAP and the decision to RSI was made. So that documents both what you were thinking, what you wanted to do, and the way that events took you, and it documents the decision making in real time. And it's an excellent example of saying, this wasn't the perfect situation. We didn't have DNR forms, we didn't have that guidance, but we did everything in our power to figure out what the patient's wishes were, what the family's wishes were, and then we made a decision to proceed with RSI. So just a few final points. Amongst the highest risk things we do are leaving patients on scene. A cardiac arrest, legally speaking, is a relatively low risk call because if you start with a patient that's dead, there's we want to see you do everything in the possible, but we also know that there's a limitation to the outcome there. But if you have a critical patient who's awake and breathing, that's a high risk call. And if you have a patient that gets left on scene, whether they refuse or if they refuse, that's one of the highest risk things that we do in EMS. So you want to document capacity. Did they have the capacity to make that decision? What goes into that? That they were an adult, that they weren't intoxicated, that they understood what was going on, that you explain to them. And we have a tendency in both in our culture and healthcare to think, oh, well, they signed something like that protects me. Your documentation is far more important than the signature on the page. Documenting what went into the conversation, what you told them, how they responded, that paints a really clear picture of what was going on, and that both clinically and medical legally is really easy to defend if you have clear documentation. So an example, recommended ambulance transport, patient refused, is able to make the decision, understands the risks, including decompensation and death. I also asked the family to help convince the patient. Family was not able to convince the patient. So that shows not just that you had a conversation, but you reached out and you did everything in your power to convince this patient to go. And that helps clinically. Medical legally, that's very powerful, because often if there were a bad outcome and the family say, well, why didn't you take them? And you have documentation saying, look, we asked the family to help and the family wasn't able to convince this person to go. We can't take this person against his will. That's really powerful documentation. The final point, and then one last point, one thing that is easy to fall into, I've done it myself, is to say you have an interaction with another agency where the other agency was the primary patient care on the call. As much as possible, document your interaction with the other agency, document your interaction with the patient. We have occasionally gotten charts that say, CAMR chart, CVFD chart, and then we really don't have a clear sense of what happened. So it doesn't have to be long, but a concise description of what, so say you arrive to find patients from a minor mechanism motor vehicle accident, no one with any complaints, all adults. Just having some brief documentation regarding that is really helpful. Any questions for me? Okay. I thank you really very much for your attention. Thank you for what you do.
Okay. Your protocols also have a little bit more in-depth stuff on how to determine if a patient is competent to make decisions to refuse or not, and don't forget that one of the things we ask you to do and document it too in your narrative is that if you need medical control to talk to the patient, put medical control on the phone with that patient, so that they can say yes, and you can document, yes, you have medical control talk. So, all right. Now on to the Travis Alert Act. This is a required education now for all EMTs in the state of Washington. The Travis Alert Act was signed about a year ago, and it was based originally on Travis King, who at the time was a well, at the time the act was signed, he was 12 years old, but when this all started was that Travis King and his family had moved into their new home in Wapato, and Travis wandered away. And Travis has a condition that's known as autism, and he was they were quite concerned that he had wandered off, and they realized that the EMS responders had no understanding of what was Travis's issue and his disability, and so they began talking with their representative, whose name is Gina McCabe, and she sponsored a bill which ultimately became the Travis Alert Act. Now, originally, the Travis Alert Bill was to deal with just persons with autism, and then the rest of the disability community began agitating that they wanted in on the action too. And so essentially this has become a bill which covers all persons with disabilities that are protected under the Americans for Disability Act. Initially the bill was set so that it could advance the E911 system so that dispatch could inform you if you were going to the scene with someone with a disability, so that you could be better prepared. It has now been expanded so that they said, well, EMTs need to be aware of disabilities and what kind of disabilities there are out there. So this is what the education for today is all about. The overall goals of the Travis Act is to maximize the safety of persons with disabilities, minimize likelihood of injury to persons with disabilities, and we died. I guess we've maximized the injuries here. What's the story on that? I'm just using this thing.
Spent too much time on the first slide.
Maybe so. Promote the safety of all persons, including EMTs present, provide tools for fire departments and emergency medical services to easily and quickly determine specific scenario in which they're, so then you would require the augmented E911 system to do. And that would happen through coordination of person with disability, letting the Pceps, the dispatch centers, know this information. This is all the information about what could be at the house, what the person's disability could be. The problem with that is that under the current rules that has to be updated about every 6 months, which makes it a little difficult. So, and then part of their training is to identify ways to maximize safety on scene for patients and providers and public, and to minimize likelihood of injury to persons with disabilities and injuries to you. So we're going to have a series of topics in which we will define the disability, talk about tips and etiquette, how you deal with people, best practices for communications, best practices for providing assistance and removing barriers, apply the checklist for disabilities, and Mark should have had and hand out, did you have the disability checklist copied? Okay, so That's required that you have that. It's required that, no. Are you going to carry this with you forever? I doubt it, but we'll go through at the end some of these things. And then identify resources. There's a resource list at the end which will be available to you. Be aware of understanding and using people-first language. That's a concept that will come up when we actually talk about what people-first language is. And be aware of how disabilities affect health, safety, and independence of people. And this will exemplify a commitment to excellence as EMS professionals in regard to care of persons, people with disabilities, others with access and functional needs. As part of our goal for this, we hope that if we were to ask you when we get done, that you could discuss and express some techniques to minimize injuries to persons with disabilities, and then understand how to use the checklist tool and express the ability to use de-escalation techniques. Now, probably, I was thinking as like, how are you going to carry this checklist tool with you? No one's going to remember that or carry it in their pocket. We can probably add that as an addenda to the stuff at the end of our protocols, so that it will be available in your electronic format. Now, will this play? Let's see. Nope. Oh, yes, it will play.
Good morning, Bob.
Morning there, man. Morning, Alice!
There's no need to be awkward.
Poor Bob. Like so many of us, he just doesn't know how to interact with people with disabilities.
It's pretty easy, really. People with disabilities are people first.
We need the same things that every person needs, like respect.
Good morning, everyone.
Attention! Okay. Maybe we need to be more specific.
The easiest way to show respect is to focus on the person, not the disability. It's okay. You'll get the hang of it.
One easy way to focus on the person is to watch the person signing, and not their interpreter.
Or their companion.
It's really cool that you'd like to help, but do us both a favor and please ask me first. What you think might be helping?
I got you.
Wait, ah! Oh no, might actually not.
If you'd like to offer me help, let me hold on to your elbow. Don't take mine.
Hey, would you like to take my arm?
Sure.
Assistive devices help us to live our lives. They're really important and really personal.
Grabbing them only makes it weird for everyone.
What?
Please only touch our devices and service animals if we've given you permission. And don't take it personally if I ask you not to. Remember that my service animal helps me all the time. Neither of us would like it if we were separated.
Remember, we make our own decisions. We sign documents, vote, volunteer, work, and pay taxes.
We get married.
So don't address me just because I have a great smile.
Just because I'm blind
May I help you?
does not mean I'm deaf.
Just because I'm deaf doesn't mean I'm blind.
And just because I use a wheelchair doesn't mean that I can't sweep you off your feet.
So take a deep breath. Relax. We don't bite.
Unless we're really hungry.
Hello there, ladies. How are you?
Hello. And if you're not sure what to do, just ask.
Hi. Would you still like to see a menu?
No thanks, but can you please read it to me?
Sure, definitely.
Just treat us the way you would want to be treated, and we'll all be okay.
Good morning. Good morning. Morning, Alice.
Morning.
Awkward no more. Nice job, Bob. Go forth and be human.
There's no need to be awkward.
Complaints,
Okay, how do I get out of this
information and
one?
referral, and technical assistance. To request assistance from the Office of Disability Rights, ODR, you
Okay.
can
Blink.
call the
Now we
agency
go
at
Go back to this
202-724.
one. Okay, so left one now.
Up. Here, let me do it real quick. I'll get you going.
Okay. Okay. As you can imagine, this curriculum is pretty well developed by stakeholders. There were stakeholders from all of the identified disability groups there for this state project. There were some of the medical program directors that participated as well. Now, Americans with Disability Acts define person with a disability as a person who has a physical or mental impairment that substantially limits one or more major life activities. It includes people who have a record of such impairment, even if they don't currently have the disability. Also includes people who don't have a disability but are regarded as having a disability. An impairment could be any loss or abnormality of psychological, physiological, or anatomic structure of function, and the disability is any restriction or lack resulting from an impairment of the ability to perform a major life activity, such as walking, feeding yourself, hearing, seeing, etc. So, and they may or may not materially affect your activities of daily life. So people with disabilities, remember, are people first. So they want to use people first language. For example, avoid wheelchair bound, confined, or crippled. A person who uses a wheelchair is people first language. A person who has a developmental disability instead of mentally impaired. A person with a disability rather than handicap. Now, the interesting thing about this is that as we go through this, we fell into using handicap sometimes too, and you all see those, what do you call those blue wheelchair signs in front of every grocery store now? You call them handicap parking. So we have to call it disability parking. That would be PC. The thing, just be nice. Use common sense. Treat people like you would want to be treated yourself. Now, when they have assistive devices, don't separate them from their assistive device unless you have to. Don't remove their assistive device from, like a crutch, from where they are. Pretty hard to use it. We want them to try to maintain independence. So deal with the person first, their disability secondly. Create an open environment. Don't make assumptions. Don't make an assumption because someone is in a wheelchair that they can't be mobile at doing so. Or if they're wheelchair bound or bed bound, that ask them, do you need assistance getting up? And once you're up, can you move on your own? Ask them what they're able to do. Avoid labels. So we don't like special needs anymore, or don't call someone, can you do this normal, or is this normal for you? Because they don't like they take offense at the term normal, because it is senses you'd suggest that they are not normal. People with disabilities may actually have excellent health. So they have the same physical problems that we will as we get older. They get heart attacks, they get other, they have strokes, they have other things that occur. Their disability may be lifelong, they may have been born with it. Their disability may be acquired. Ask before helping. Like the lady who was going through the door. She didn't need assistance because she was using the door to help her maneuver through the door. And when you took the door away, she'd lost the crutch. Value independence to the extent possible. Now, in the EMS world, all things are off when you have a true emergency. So if you have to exit the building quickly, you can't be as nice as you would normally be. But most of the time we don't have absolute emergencies when we're doing EMS stuff. You know, the true emergencies are reduced. Speak to the person directly, particularly a person who's deaf. Talk to them, watch them. They're reading your lips more than often. Watch them, don't watch the signer. Use patience, respect, understand that people with certain disabilities, particularly developmental disabilities, may take up to 2 minutes to process what you told them in order to make a response. They are not ignoring you, they're just processing. Avoid interrupting. Nobody likes to be, just be nice, nobody likes to be interrupted. Use one, I should say one, not once, one direction at a time. Don't give them, especially developmental disability, don't give them many choices of things to do. Adults are adults, treat them like adults. Use your regular voice. You don't have to yell at blind people or deaf people. It's okay to use language about abilities. Ask them what they're able to do. Ask personal questions if necessary. Look for ID bracelets, necklaces, information that's handed out. The most important tool in communicating is treat everyone with respect, treat them just like you would expect to be treated. So, shake hands. Now, with the proviso, as we get to developmental disabilities and to autistic spectrum disorder, they may not want to shake hands. They may not like personal contact. And so you talk to them and say, would you like to shake hands? When I meet a patient in the emergency department, when I would, unless it was a dire emergency, I would go in and introduce myself and shake hands. speak directly to the person. If you don't understand what they're saying, ask. Tell them, I didn't understand. Can you repeat that? Match your vocabulary level to their vocabulary level. When I was in medical school, one of my co-students was interviewing a person who had 2 PhDs. And she asked him if he had any trouble making water. His vocabulary certainly would understand urination. So, match your vocabulary level with you wouldn't ask a child of 6 if they have trouble urinating, but you could say, does it hurt when you pee? That a 6-year-old can tell you. Speak your typical style. Don't be grandiose. Don't change. Ask if they have a preferred communication style, particularly the persons who are deaf or hard of hearing. They may like to communicate by writing things down. They may have assistive devices. The list that is at the end of this, which can be available to you, has community resources in this area that would provide benefits both for EMS and for other community members. Some of the communities, particularly like the deaf community, are very proactive. All right, the first module, people with mobility and physical impairments. So, this may be difficulty walking, difficulty with balance, difficulty with arm movements and coordination. It may come from this list of conditions that may give you mobility or physical impairments is not fully extensive, but includes conditions that you're essentially congenital, you're born with, such as cerebral palsy, dwarfism, spina bifida, and then a thing called developmental coordination disorder, absent limbs, reduced limb function, and then things that happen to people as they're exposed to viruses, to infections such as poliomyelitis, post-polio syndrome, things that they get from injuries, spinal cord injuries, other neuromuscular disorders, amputations, etc. So all things that would give you physical issues. Now, ask the person with a disability how best to move them or to assist them. So if they're bedbound, or if they're in a wheelchair, or if they have an assistive device, ask them if they've been transported before and how that went and how it was. Ask people, do you need help getting out of your chair, or are you able to get up? Many people in wheelchairs are very good and are very strong, and they're very good at moving from chair to chair, different positions. Ask them if once they're up, if they can move without assistance. Now, obviously, if it's an emergent situation, you sort of have to work quickly. Don't separate people from their assistive devices. So if they have crutches, make sure that, or a cane, make sure you bring it with you. If you can't transport them in a wheelchair, and most ambulances don't do very well with wheelchair, you may, if it's not an emergent situation, you may call for a wheelchair type of car in order to transport them, so you keep them in a wheelchair. Ask before you begin assistance. Don't make assumptions about their abilities. Bring the crutches, canes, other things with them. And there are ways, do you all understand how you can move people in non-motorized wheelchairs out of a house? Hopefully, you'll be able, hopefully they're in a house, they're in a situation that has, if they're in a wheelchair, that they have a ramp device. If they don't, you know, if they're in a situation where they're up a stair, can you safely bring someone out in a wheelchair? A non-motorized one, yes. How about a motorized chair? They're a lot more difficult. Sometimes they break down, sometimes, no. So you will probably have to transport that patient out of their situation in a, on a gurney. All right, people with sensory impairments. So big D and little d deaf and hard of hearing. Big D deaf is people who identify themselves as being part of the deaf community. And before we started this project, I wasn't aware myself how extensive the big D deaf community is, and the fact that they really identify as being deaf, and they're not persons with deafness, they're deaf persons. That's just the reverse of the people first idea. They have a whole cultural identification, and they may be, and most are probably persons who are lifelong deaf. They were born deaf or became deaf due to childhood illness or development very young, and so they often identify, and they often are very good at using American Sign Language. So they will, and they're also often very proficient at lip reading. Whereas little d deaf are usually people who are hard of hearing or have developed this as they went into adolescence and adulthood, from infections, from inherited things, from injuries, and they often don't know, because they never had a chance to learn sign language. So they don't identify often as being culturally deaf. Hearing impaired runs the gamut of people who are profoundly hearing impaired and understand that and consider themselves to be essentially deaf, and those who are hearing impaired and simply deny it. My father was one. He refused. He refused hearing aids. He refused any assistive devices, and he was profoundly hard of hearing. But whatever the cause of and how they identify culturally, a person who is deaf or hard of hearing may display, when you're trying to deal with them, that they don't respond or appropriately respond to your interview, your questions. They're asking for repetition or clarification. They may stare intently at your face, especially if they know how to read lips. If they seem confused about what you're trying to say, or they may point to their ears or mouth, shake their head, yes or no. So look for other cues, like do they have a visual doorbell, flashing light doorbell? Do they have telecom equipment, TV captioning? Are they using sign language? Do they have a hearing aid? You can ask them if they have a cochlear implant. You won't know that right off the bat. But also they have visual fire alarm systems often. All cues. Now, I said the people who are culturally deaf, big D deaf, don't like people first language. They want you to say, they want to consider themselves a deaf person, not a person who is deaf. They may have a pre-written note or card. I am deaf or hard of hearing, and what you can do to communicate. This will give you some ideas in communication. They may prefer one of several communication techniques. So if they're proficient at reading lips, they will tell you, they will indicate that to you. Then it's your job to, when you talk to them, to look directly at them, get their attention. They suggest that you wave your hands. That seems kind of rude to me. I'd say maybe touch them to get their attention and speak directly to them so they can read lips. They may prefer sign language, and often there'll be a person at the house, if this is their residence, that is proficient at communication. When you communicate, still talk and look directly at the person communicating. You can hear the interpreter. You don't have to look at the interpreter. They may want to write. They may want to use an assistive device. They may want to use an iPad to communicate. There are a couple of devices out there that use that have translators that will translate voice into script. Medical visual language translator, which is I think it's available for on a Microsoft platform. Many people will have, many people who are big D and little d deaf will have telephone communication assistive devices as well. You can use that as a way of communicating. Now, people with other sensory impairments, blind, low vision, or visual impairment. Blind theoretically means the inability to see dark and light in either eye. Legal blindness is not a medical term, but what it means legally is that essentially the person's best eye, best correction with maximum ophthalmologic or optometric correction is still 2200, or has a best visual field of less than 20 degrees, which means you're pretty well narrowed to a tiny thing. Now, blindness means lack of sight. Low vision and visual disorders, their low vision can be either the form of a narrowed visual field such as with macular degeneration, but which with assistive devices can still have some visual acuity. And low vision usually means that you have best correction with maximum correction is still less than 20/40 in the best eye. That's considered low vision. Now with low vision, many people with low vision are still out there driving. Yeah. And the visual field is would be the worst part, because a person with macular degeneration is not going to see much out here. Now, not everyone, of course, who is blind became blind, has been blind lifetime. So, as a matter of fact, ocular complications of diabetes is probably the most common cause of blindness in adults. Macular degeneration happens to about 3 to 4% of our population as we get older. Lots of inflammatory disease can occur, and you can lose, you can have glaucoma, which is very common cause of blindness. It used to be very common out in third world countries, less common now because we test in this country, and there are certainly treatment for it. Chemical poisonings can cause blindness. Of course, congenital abnormalities, injury to the eye, hereditary disease of the eyes, and then malignancies to the eye occur. Now, obviously, in people who are blind or low vision or visual impaired, always communicate written information verbally. If you can't read the menu, don't give them a menu. You have to read it to them. Most people who are blind or have low vision are usually extremely self-sufficient, unless they're, especially people who have blindness for a long time. And they have, you know, if you're blind from birth, you're probably a Braille reader because you get taught that. People who become blind at a later time don't usually learn Braille. If they have service animals should be transported with the person. There's a whole section on service animals coming up. Now, a person who is blind might communicate using written messages. They might have some pre-recorded messages that they can hand you so you can, but if they're low vision, and even if they're blind, still look at them, try to establish eye contact, ask people who have low vision or blind, where do you want me to stand? One of the tricks also about people who are blind is that when you go in and out of the room, reintroduce yourself when you come back. You say, hey, Marge, this is Tom, the paramedic. I had to go out to get something, and I'm back now, because they don't see you coming in. Now, if you're going to have print material for particularly, it doesn't work for the profoundly blind, but for low vision people, we make print material in large print. Or if you're going to write something out for them, don't write it out with a ballpoint pen. They can't probably see that close. Write it out. You use it like a magic marker kind of pen, something that's broader, and write big. So people with macular degeneration can read that by looking at it really close, and they'll follow it letter for letter for letter. Now, in a true emergency, when you need to exit the building quickly and you don't, you know, they're blind, they're not deaf, so you can tell them this is a real emergency, but a universal sign for blind and / blind deaf persons, which is coming up next, is draw with your finger an X on someone's back. That indicates an emergency. Now, not all deaf people, not all blind persons understand that. But with the blind, if they're not deaf too, just tell them that, you know, I said, we have to go now. Now, so, deaf blind. Well, what is that definition? That is a person who has both deafness and blindness. Now that may be, or so deaf / hard of hearing, blind, or low vision. That may be a person who's born with that, has a developmental disability with that, who has, or a person who has had an injury. Sometimes people, particularly, sometimes persons who are in explosions become deaf and blind as a result of that. So, a deaf blind person may not respond or may respond inappropriately. They're asking for repetition, they're staring at you, they have visual, they have the same things that deaf persons have, visual equipment to alert them to fires, alert them to a telephone or a doorbell. Saying no, shaking their head, pointing at their ears, no, or using sign language, or totally confused, has a hearing aid, etc. They may not be immediately identifiable, especially in an emergent situation. Deaf-blind doesn't always mean totally deaf and blind. So be nice, don't talk bad. If someone reaches for your hands, which is a tactile sign, and then they try to write letters in your hand, or you can try to write letters in their hand, that's something that deaf blind people will do. Or, and this is the odd one, is a thing called tadoma, where it's tactile lip reading. They will reach up and they'll find your face and then put their fingertips on your lips, and they can read lips through that. Now, that may be an attempt to commit. Now, that most of us might find that a little bit invasive of our own space too, and that's understandable. But that is a real thing, and that may be their only way of communicating. They may have written message or pre-recorded message. They may have an ID band, an alert band, which tells you what their problem is. Remember, they may be low vision, and so eye contact, if appropriate and possible. Ask people who are blind or have low vision, where do you want me to stand so they can best see you. It's probably not a good idea for you to stand in between the light and them, because they won't be able to see you. You'll look dark. You have to stand to where they can see you in the light. Check frequently for understanding. The persons who are deaf-blind frequently understand the X on the back is, we're out of here. This is an emergency. Okay, we need about a 10-minute break. people with mental health, cognitive, intellectual, and developmental impairments. Well, there's a lot of definition as to what that means. But the general thought is that people who have severe mental health issues, whether it's schizophrenia, severe anxiety, phobias, whatever, or have cognitive understanding and intellectual disabilities or developmental impairments, may not respond to emergent situations the same way that the rest of us do, or their response is extreme. For example, if they become very agitated with lights, sirens, they may not understand at all what is going on. They may be able to read, may not be able to read. They may not be able to make reasoned decisions. They may respond very negatively to uniforms. They may respond negatively to being touched. General etiquette when you're dealing with mental health issues or persons with cognitive, intellectual, developmental impairments is allow them to complete his or her sentence. Don't interrupt. Now, this may take a little time. You have to be, now, obviously, you may feel pressured because of the situation yourself. Be empathetic toward the person. Remove them from confusion and reduce distractions. Turn off the siren. Turn off the lights, the flashing lights. Now, what kind of mental health issues are we talking about? We're talking about standard mental illness, including schizophrenia. A mental health issue becomes a disability when it materially affects that person's ability to function in activities of daily life, or to keep a job, or to take care of themselves, or to, just to take care of themselves. So, mental illness may be controlled with medication, and it may, and then with a abrupt emergency becomes out of control. Now, anxiety disorders are things like phobias. There are things like sometimes your phobia may be just a free-floating anxiety. These present often as with symptoms very similar to an MI: chest pain, shortness of breath, palpitations. And they're aggravated by the presence of emergent things like flashing lights, like sirens. Maybe social phobias. A psychiatric mental illness may not be a disability, but if it is, it's a psychiatric disability. Mood disorders are mostly things like depression. Now, mental health disorders can be mimicked by real things. So, learning disability may appear to you to be a mental health disorder. It's not. It's simply, and intellectual disability may also appear to be mental health disorder. Autism may appear to be a mental health disorder, but it is not. It's a developmental disability. Traumatic brain injury, no. And PTSD is, in one sense, a mental health disorder, but it's also traumatically induced. Traumatic brain injury may appear to be mental health disorder. Remember, most people who are mentally ill are no more likely dangerous than the general population, but they agitate, they frighten us because there seem to be, their behavior is unpredictable. And it may appear to be aggressive, but that, generally speaking, does not mean that they are dangerous. Respect their personal space, and respect their belongings. Now, consider differential diagnosis. Consider that, is this mental health disorder or is this a development thing? Don't get tunnel vision and saying, yeah, he's acting crazy, so he's got to be crazy. Don't give multiple commands. Ask for one thing at a time. It's okay to give them a time limit. Sometimes they seem to waste all, you're thinking, oh, this person is going to waste all my time trying to figure it out. Say, we only have 5 minutes. We need to get some answers here. Or give them a direct thing. If you scream at me, if you yell at me, I can't help you. Give them concrete things to deal with. If relax, stay calm, present an open stance, listen to them, watch out for contradictory messages between verbal and nonverbal messages, so that so don't tell them something to do and you're actually acting differently yourself. If you become agitated with the person or frustrated with the person, understand that you may not be the one to deal with this person, and try to pass that off to a partner. I think all of us have been on cases where someone who was mental health disorder or developmental disorder or autism spectrum disorder seemed to bond with one person on our team. And that person always then gets stuck dealing with that person from that, because that's who they ask for. And the thing with mental health patients is we often see them more than once. So they'll be the frequent flyers. Turn off your lights and sirens if possible. Once you establish rapport, as you do with that patient, try to maintain continuity of care with that person. Usually if you do handoffs, after you've established rapport, that doesn't work out well for the next person. Call for help from mental health if available. Now we do have, there is an adult crisis response team now. And they are so far guaranteeing us they can be at the scene if they're available and they pick up the phone and it goes through CRESA. They can be there within 20 minutes or less. So now, cognitive disabilities. So that means learning, intellectual, developmental, traumatic brain injury. These are difficulty with understanding or being able to integrate what you hear, see, and feel. So classically, often these are developmental disabilities, but and most cognitive and learning disabilities are developmental or inherited. Dementia is a different Dementia is an intellectual cognitive problem that develops as we age, and not everybody gets it. You know, the classic form is Alzheimer's, which is usually a 10 to 15 year slow degeneration. There's a couple of subforms of dementia that are very rapidly progressive, and some that never seem to get very bad. But the same thing, they still have difficulty understanding and remembering. Traumatic brain injury is exactly what it is, and it all comes in all forms of severity. Of course, we see a lot of traumatic brain injury now out of the Middle East and the military. Now, conditions that may exhibit characteristics of cognitive disorder are a thing called auditory processing disorder, where people cannot seem to be able to cognitively process what they hear. They can't put it into action. They can't put it into an idea, a thought process. Aphasia, obviously aphasias often occur after strokes. Aphasia is simply, you can have auditory aphasia. It means you can't process words. You can have visual, you can't process what you see. You have cognitive aphasia. It means you can't put the two together. You can't process them into words. Dyscalculia means you can't add, subtract, etc. Then get down through all these other, and then there are developmental things that are determined genetically. Fragile X syndrome, which is more common in boys than in girls, let's say one out of every 2,500 births, 2,500 to 4,000 births, so a very low percentage, but Fragile X has, they seem to develop normally for the first 6 months, and then it's downhill from that point on. They have developmental delay. They can't hold their head. They can't hold their head up. They can't stand. They don't learn to walk and move about. They're intellectually impaired. They're essentially have to be taken care of the rest of their life. Down syndrome, we're all familiar with Down syndrome, and has varying degrees of intellectual and cognitive disability. Attention deficit disorder is in the developmental disorders realm, and also associated with hyperactivity. Subdural hematomas, brain aneurysms, etc., can cause developmental, cognitive, intellectual dysfunction. Then autism spectrum disorder is in this list of developmental disorders as well. Now, with the developmental disorder, very much like the mental health disorders, be patient, allow the person time to think and answer any questions independently. Now, with severe Alzheimer's disease, they won't be answering questions probably, or repeating the same thing. Ask about the best way to relay information. Ask the caregiver. Usually it'll be a caregiver. Use clear sentences, concrete concepts, a lot of yes and no questions. If you're not sure what you understood or whether they understood, repeat it for verification. if someone is nodding, and it doesn't make any difference whether, no, whatever, that if they're nodding yes or no, that doesn't mean they understood you. That means they're nodding. You have to confirm that. Ask them to, if you say, hey, do you understand? And they nod their head, the next thing to say, what did I just tell you? Now, try to establish rapport, choose the appropriate language for the age of that person and the intellectual age of that person. Listen, explain clearly, and sometimes it's better to show them pictures than to speak. So, now we're to the beginning of where this all started, which is autism. This is how the Travis alert started. So autism spectrum disorder is a spectrum of developmental disability and difficulty in cognition. And it varies from severe autism, which is the classic unable to communicate child who's any stimulation is maybe too much, and the child would be classically sitting there rocking, not communicating, or making making noises and banging their head against a wall, because that's a stimulation. They're not reacting to the environment as one would do. Now, then the other end of the spectrum is, and is everything in between, is people who have who are actually very intellectually superior and have difficulty making social contact because they cannot, they don't understand, and their cognition doesn't include interaction with other people. So, and then there's like I say, everything in between. And some people, sometimes they have repetitive actions, sometimes they have what appear to be tics, sometimes they will, in the case of like Tourette syndrome, they will shout obscenities suddenly. Or they have facial tics and grimaces. One of my brother-in-laws has Tourette's, and he's a professor of microbiology. So, I mean, they're quite. But he doesn't curse, which would have been more fun. He just has facial tics. I mean, I curse, and you know, and to my knowledge, I don't have any of those things. But he's so. You know, and the classic, the movie version of autism disorder is Rain Man. And they can do some repetitive thing, but their social interactions are very flat. They often can't tolerate eye-to-eye contact. This is one of the people that you shouldn't force them to make eye-to-eye contact, because they can't do it. There are sometimes they appear, because especially if they're agitated by by an emergent situation or a special situation that triggers them. They may appear to be mentally ill. They may act like a schizophrenic. They may be obsessive compulsive, have hand wringing, have repetitive things, go in and stand and switch the lights on and off. They may have a language disorder. They may appear to be deaf or mute because they're not talking to you, and they're not, and they may appear to be under the influence of drugs and or alcohol, and the sense that they don't respond to your commands. They don't respond to police often who say stop. You know, the rest of us know what that means. They may not know that. They may not respond to that, particularly when they're agitated. Be clear, direct, avoid figurative language, you know, fancy stuff. Just give them simple stuff to understand. Approach in a quiet, non-threatening manner. Give them a lot of space. Don't try to hold them down. Don't threaten the person with punishment. That's why the police don't often work out well with that. They don't know TLC very well. When interacting with caregivers and parents, allow the parent to tell you the situation before reacting to the situation. Use a calm voice. Sensory overload is a major barrier. Be clear and direct. Get that quiet space. Now, this is an interesting one to me. Remind search and rescue personnel to consider looking in and around nearby bodies of water when searching for a missing child with autism spectrum disorder under the age of 14. And I looked it up, and for some reason these kids seem to be drawn to water. I don't know if it's something to do with Darwinism or not, but they're drawn to water, back to the water. And more often than not, and then indeed they found Travis when he was 6 years old, who wandered away. They found him in a creek bed down in the creek. So also consider what behavior is necessitating this acting out. And so, for example, if a kid is maybe stopped by the police because he's been at the 7-Eleven or a grocery store and he's stolen some stuff, it may be that he's hungry, he's out of his favorite thing at home, but he knows where these things are kept at the grocery store, and he doesn't know that taking them from the grocery store is kind of frowned upon unless you pass some money back and forth, because they don't understand those consequences. They do know where the food is. Identify other resources. Sometimes you will get one thing with autism spectrum, when they have a quote meltdown, that's going to take a time for that to go away, and that usually means you have to separate them from the situation, get them physically, just let them get away from that spot. So if they're not endangering themselves, let them move away from that spot. A meltdown is not the same as a tantrum. A tantrum, when you provide the reward, the tantrum stops. a meltdown is total loss of control. So you can't provide the reward. You just have to let it burn itself out, and usually it'll burn itself out if they're not in that situation. Okay, now we have over here just the perfect thing for this part. Now we need to talk about people with service animals. So, and we have that lovely little service animal. Yeah. And the service animal has his tags and everything else on too. So right now we have service dogs, therapy dogs, and emotional support animals, which to my knowledge could be anything including ferrets and snakes and mongoose and anything else. Yeah, but and miniature horses are included under the service animal definition now under the ADA. And things that are covered under the ADA, under Title II and Title III of the ADA, means that you have to provide access to public transportation. It includes ambulances for the service animal, the service dog. So now there is a difference, and there's a little comparison chart here. Service dogs are covered under the ADA, whereas therapy dogs and emotional support dogs are not. Now, and of course we all, has anybody been on an airplane in the last couple of years, 3, 4, 5 years? Yeah, well, now you'll see someone with a dog on their lap, or dogs in the airports barking and snapping at you, and they do not have service dog tags on them. They're just dog. And these are often, and the problem is we can't, and I'll tell you in a minute, you can't ask, or at least the airline can't ask, but sometimes these are people. I'm aware of a woman who travels with her 2 dogs, and she has no more disability than I do, but she got her vet to say these were service dogs. Well, they're not. She just wanted her dogs to go with them. Now, this gives the service dog handlers a bad name, because everyone gets ticked off at somebody who's, there's a little lap dog sitting next to you who, snarls at you every time you look over. And they don't give you free drinks for that either. So a service dog needs to tolerate a wide variety of experiences. Also, therapy dog does. Now, so service dogs, the primary function of an emotional support dog is to provide emotional support through companionship. Now, an emotional support dog is not supported under the ADA. So, types of service animals are guide dogs, mobility assistance dogs, seizure alert dogs, and they may be dogs that are not what we classically consider a breed for a service dog. They may be a much smaller dog, and they seem to be able to sense the pre-aura, or the aura of someone who's about to go, and then they alert the person to either take medication or lay down. Psychiatric service dogs will remind people that it's time to take their medication. And then there are fetal alcohol spectrum disorder dogs, which are the same thing. They're essentially guide dogs. hearing dogs for persons who are, you know, they will alert you to the fact that there's somebody knocking on your door, or there's something you should respond to. Diabetic alert dogs sense changes in blood sugar. Now, what they probably do is don't sense changes in blood sugar as much as they can sense ketone bodies, or sense the absence thereof of normal normal amounts of ketone in the breath. We already said seizure response dogs, you know. Then autism support dogs. That's both for companionship and to allow the person to feel comfortable and relaxed. Allergy detection dogs, they don't detect bees, they detect nuts and things like that. They're trained to detect that in foods. Now, the service animal is a piece of medical equipment. That's what the ADA says. It should accompany the person. When it is not obvious what the service animal provides, you can ask two questions, and these are the only two questions you can ask someone with a service dog, or if you say, is this a service dog? Is the dog a service animal required because of a disability? You can't ask what the disability is. Just say, is it required because of a disability? And then you can ask, what work or task has the dog been trained to perform? Service animal must be harnessed, leashed, tethered, unless controlled by voice or signal command. The service animal also has to be housebroken. Now, there you have the miniature horses. These things weigh up to 100 pounds. Yeah. Now, talk to the handler normally, leave the dog alone. A service animal normally will have a signage on it that says, please don't handle, please don't pet, etc. Avoid saying insensitive things like, gosh, I wish I had a service dog. Yeah. It's impolite and, in some cases, illegal to ask a person what his or her disability is. So that's reiterating that previous point. Know the federal law providing service animals. Service animals are allowed anywhere the public is allowed. Public transportation systems must allow service animals to travel with their handlers, including ambulances. Okay, now, in summary of this whole Travis Alert bill for EMS, put the person first, his or her disability second. Don't make assumptions about needs, abilities, or limitations. If the person needs help, he or she will likely instruct you on how to best give its assistance. Ask. Be sensitive about physical contact. Always speak to people with disability directly. Don't talk to their translator. Talk to them. And then review your ability checklist. And very quickly, your ability checklist. Immediate action items, safety of EMS personnel and bystanders. Respect personal space. Use a calm tone. Include the patient in planning and decision making. Assess and treat immediate life threats. Any immediate life threats, you don't have to be nice. You don't have time to be nice. I mean, you have to be nice, but you know what I mean. You don't dilly-dally around with someone needs CPR, you have to do CPR. What physical barriers need to be removed in order to help this person? Consider the need for outside resources, consider mental health, consider police as you need it. Transport for mobility issues, transport assisted devices used by the patient whenever possible. Arrange for alternative transport if it's not possible to transport the device. Consider using the same method the patient has been transported in the past. If it worked in the past, it worked this time. Request other resources. Call for the bariatric vehicle if you need it. Determine the degree of visual deficit in a vision. Speak directly to the patient. Don't shout. They're not deaf. Don't use non-specifics. Watch out. You don't know. One of the other tricks with the blind is if you have to move something like their furniture in in order to get the gurney out of the room, put the furniture back where it was. Because when they come back in, they're used to how their house is set up. This is how they get around. They're going to fall over something on the way in. If they're ambulatory, offer them your elbow. Don't take their elbow. Don't take their cane. They're using the cane to find it. Tell them if you're going to go up a step or down a step. Determine if assist devices or service animals are used. Bring those. Hearing deficit, determine the degree, determine what communication techniques work best. Ask the person, ask the interpreter, look for someone to help you communicate. Mental health, key things, which we didn't talk about in that, but whenever you're dealing with mental health thing, you should check blood sugar. Remember that. Now, you're going to say, oh, well, gosh, so I've got a person with cognitive difficulty like autism spectrum disorder. I'm going to run up and poke them in the finger first thing? No, but you somewhere along the line, you should probably check that. Particularly if you don't know. Now, if the parent is there and says, or if you've been dispatched by E911 and they say, this is an autism spectrum disorder house, then you can have a better way to deal with that. But unknown mental health conditions, somewhere along the line we check, because for years we've been saying that mental health issues often are mimicked by low blood sugar. Consider differential diagnosis, medical and other traumatic conditions. Avoid sensory overload. Calm voice, avoid escalation. If you're getting it on with the patient and it's not going anywhere, get your partner to help. Use an open posture. Avoid prolonged eye contact. And consider other resources, mental health and police. Autism, avoid sensory overload. Discuss requirements for successful interaction with the caregiver. Calm tone, acknowledge, validate emotions. Service animals checklist, assure service animal is transported with the patient. Request additional assistance if the animal cannot accompany the patient for some reason. All right, there's the whole list of community resources that'll be available online. Okay. And there's Travis at age 12. All right. So we have some case reviews. And you have, yes, that's in the case reviews, isn't it? Yep. Okay. All right. And there's a couple protocol changes too, which you'll probably like. All right. Number 1, called to a private residence for a 37-year-old female who had reportedly jumped or fallen from a balcony. Found the patient laying down an embankment in a blackberry bush behind a private residence. Appeared only partially conscious and in obvious distress. Patient husband on scene said the patient jumped from the 3rd floor balcony to the ground. Spouse states the patient has a history of psychiatric problems and more than one previous suicide attempt. Down a steep embankment, partially tangled in a thorny blackberry bush. Slight delay in getting the patient packaged and extricated. Extricated using a long spine board and C-collar for immobilization. Once we got the patient in the ambulance, she appeared cyanotic around her lips and a grossly altered mental status with a GCS of 6 to 7. She weighs about 80 kilo. Pupils equal reactive, small amount of blood and sputum in mouth and nose, neck atraumatic, chest equal rise and fall, abdomen distended, small scrapes and abrasions in the back, left shoulder dislocated, appears dislocated, small scrapes, etc. Some spontaneous movement did not follow commands. Patient sedated and paralyzed for intubation, ventilated first with a BVM, IV was established, nasal cannula applied for apneic oxygenation. C-spine was held manually for intubation. Patient had blood and emesis and airway. First view, after suctioning, had a brief view of vocal cords but lost it attempting to pass the tube. Tube was passed through the area where I'd seen the vocal cords, but after one ventilation, it was clear the tube was in the esophagus due to tube filling with emesis. Tube is immediately removed. Patient was then ventilated and reoxygenated. Attempted one more look, was not able to get a view, did not attempt to pass the tube. We switched rescuers, again ventilated, reoxygenated with BVM before another attempt. Visualization attempted, cord viewed. Tube was passed, ET tube was confirmed with the presence of bilateral lung sounds, tube misting, and a positive numeric ETCO2. After the first intubation attempt, patient's heart rate dropped, so atropine was administered, heart rate came back up after further attempts. Patient's heart rate dropped again, so another round of atropine was administered. Why was the heart rate dropping? Low, 2 sats more than anything. At this point, we were in the back doors of PH Southwest, prepared to move the patient aside. Had a pulse at the time we unloaded, prepared to slide the patient from a gurney to the hospital bed. She went into cardiac arrest. Chest compressions initiated as they assumed care. Tube was confirmed by ED physician. So this gives our list. She had a CO2 value of 20 after, well, this is before intubation, so you're probably hyperventilating a little bit, 99% on O2. Then 92% O2, atropine was given, pulse ox 100, atropine given again after intubation, CO2 was 8. I'd say she wasn't, if there was a waveform present and there was 8, that we were considerably low on cellular activity at that point. Okay, so Dr. Fedor reviewed this chart. It said, this is an excellent chart. The scene itself and the mechanism are well described. So you get kudos for the, and you hadn't even listened to Dr. Mock's presentation this morning yet. The extrication story points an appropriate level of complexity and difficulty in medically managing the patient at the same time. The intubation portion of the narrative is great. It describes preparation, attempts, and what was changed in between attempts very well. It leaves very little to our imagination, which is what we want to see in an intubation chart for sure, because that fills, the drop downs in the intubation just do not give us a picture of what went on. And it's very hard to figure out from the drop down how many attempts were done, often. So, only suggestion might have been to slide a bougie to start with. If you can see the cords, you can usually get a bougie in there. So the tube frequently blocks your view. And it would also be a good idea to try to intubate with the stretcher at full height outside. It's much easier to work off a. There's a reason, like I keep telling you, there's a reason we don't intubate people in the ER on the floor. Not the least of which is we know what's been on the floor. Yeah. A lot of these difficult airways are much more difficult in the confine of an ambulance. Now, with severe injuries, the patient resting on arrival, you can expect this didn't go very well, and with that CO2 of 8, he didn't do very well. Patient had a catastrophic retroperitoneal bleed. Nothing that was amenable to repair despite aggressive surgical treatment. So she went to here's the hospital report. 40-year-old, 40s-year female, witness jump, EMS arrivals, GCS of 6, blood pressure 80 of 30, heart rate of 110, emergently intubated on scene. Now, with a blood pressure of 80/30 and a big retroperitoneal bleed, one would expect that she'd have a heart rate in the 150 range at least, you know, a massive bleed, but your heart rate slows down as you're dying. And also, retroperitoneal bleed will probably give a fair amount of vagal stimulation there too, so you got to you're kind of fighting both things, which also might explain why she without a severe desaturation, why she slowed down after the first intubation attempt with sucks. So she went through the primary survey, etc. Well, anyway, so both pupils by the time they took her to surgery were blown. They did a clamshell thoracotomy and direct cardiac massage. No blood was in the chest, no tamponade. Cross-clamped the aorta, then had a return of spontaneous circulation with a blood pressure in the 80s, went to the OR. She had spontaneous circulation and blood pressure in the 70s in the OR. They did a midline laparotomy, went down into the peritoneal cavity, didn't find any volume of blood there, and packed the upper quadrant because of some general oozing, and then had a large zone 3 retroperitoneal hemorrhage. She went into PEA arrest this time despite carotid massage, ongoing resuscitation, lost all cardiac activity, and was pronounced. So, start to finish, basically got everything done that it was humanly possible to do for someone who, was intent on killing herself. Oops. Okay, number 2. Responded to scene for an MVC between a large passenger-type Sprinter van and a small child. Upon arrival, patient was found lying supine, immobilized on a child backboard in the driveway of patient home, alert, crying intermittently. He was being tended to by mother and EMS. Airway was patent, respiration normal, non-labor. Skin vitals normal with tachycardic pulse rate. According to Fire and the child's mother, who says she witnessed the event, the patient was caught and run over by the right rear tire of the van. When she got to him, he was conscious, crying, with strong breathing and multiple abrasions, traumatic injuries about his body. States he was essentially folded over, lying in the driveway with his head to his knees when she went to grab him. 911 was called. When fire arrived, they noted the injuries and suspected the child had been completely run over by the van. ALS fire immobilized the patient to a backboard, assessed pulse, obtained IV access. Lead medic also advised he spoke with the doctor at PH Southwest to get clearance to bypass the facility and transport to Emmanuel. Has anybody got a question that this child is going to be admitted? Okay, neither did I. And we don't keep pediatric traumas at Southwest. So the physician advised the child needed to be transported to PH Southwest first. The lead medic could not supply the name of the doctor. We won't supply that either. But advised, they definitely said to transport to PH Southwest. Supervisor, also on scene, called to get clearance to bypass, but he was also met with resistance with the doctor. Patient was loaded, the ambulance taken to PH Southwest en route. The patient was monitored throughout. Condition remained stable, unchanged. Did not appear to be any grave danger going into cardiac arrest and no airway concerns. Toward the end of the transport, the patient did calm somewhat at a GCS of 15. Ongoing vitals assessed, patient was transported without incident. Upon arrival at the ER, patient was moved to the hospital bed and care transferred to an RN, ER doc, and the trauma doc. After the report was given, the trauma doc said, "Could you stick around? Because I'm going to transport the patient to Emmanuel." Duh. Okay. So, and they did. So enough said on that one. Now, so now you can be excited about this. I'll get up to protocol adjustment. Pediatric trauma diversion. Transport all pediatric trauma entry patient to pediatric level 1 hospitals unless closest hospital necessary for airway control, vascular access, or arrest. If you don't need vascular access, don't, that's not a reason. You don't have to have an IV in it. Now, granted, in pediatric trauma, you probably want to have IV access, but they had IV access in this case. There wasn't an issue. Now, an arrest, traumatic arrest or otherwise, I don't want that one transported out of county because there's no reason to go extra length of time. For a long transport or traffic issues, consider activation of life flight. And you can use either helipad as a logical thing, just pull in and go to the helipad. Or if you have your other LZs. Now, here's the part you'll like the best. Medical control at PH Southwest contact is not required for transport to Portland allowed by county operating procedure. So burns, pediatric trauma entry, pregnancy with multi-system, and I don't mean, oh, I think I'm pregnant. I mean, yes, you're pregnant because you look like you're almost ready to deliver pregnant. 3rd trimester pregnant with multi-system injury. Document that document why you're going to a level 1 on your MIR. That's going to come to me. You don't have to call. Now, you can call medical control if you want advice. And you can always go to the closest hospital or to the closest trauma hospital if you're uncomfortable. We're not going to give that. This is for your comfort. But on cases of trauma entry, and I don't want it to be, oh yeah, he broke his arm, I'm going to go to Emmanuel. No, trauma entry patients, if they fit trauma entry criteria, and I know they're going to be admitted and observed at least overnight. You'll save them an extra trip, you save them some time. We've got at least one case we know that it would have been better to go. No. It's impossible, entirely impossible to absolutely predict bridge lifts. It's also not possible, you know, there are going to be extenuating circumstances where you need to use your judgment, but the preferred thing is take trauma pediatric entries to a pediatric capable hospital. Okay, so back to number 3. The kid, by the way, surprisingly enough, had some, out of all of his, he did excellent and was only in the hospital for a day or two and had a minor, a couple of minor non-fixable pelvic fractures, and also they thought a bladder injury, but that didn't actually turn out to be. So, which he really lucked out. Goes to show that certain ages are very squishable. Dispatch priority 3 on a traffic accident. Patient restrained driver driving a mid-size 4-door car when attempting a corner at over 80 miles per hour. Missed it, went into a tree. Skid marks down the road before going off the road and traveling approximately 30 feet down the side of the road and about 20 feet into the brush before resting against a 14-inch tree. Exterior, boy, that's a good, see, lots of good description in this. Exterior of car had severe damage to passenger side that impacted the tree, 2 feet of intrusion, roof was crushed. Front had severe damage, entire car was in a large V shape. Interior had severe damage with windshield and most windows broken, dash not intact, unsure about airbag. Everything in the car pushed toward the driver from the impact. Manual C-spine being held by a bystander, continued while EMS applied a collar. IV vital signs, patient being assisted with ventilation with BVM while waiting for fire to arrive to extricate the patient out of the car. Approximately 25-minute extrication time before patient was removed on a long backboard and placed on the gurney. Fully C-spine while assisting with ventilation and suctioning the airway due to the blood coming out of his mouth and nose. Suction was continued during the entire call with approximately 500 cc's of blood being suctioned from the patient's airway. En route to LZ, patient given RSI meds and first attempt was done. At intubation, cords were visualized the MAC4 and suction. A 702 with an Eshman was attempted but unable to pass the cord. Attempt was stopped and BVM continued. At LZ, life flight got in. Report was given. Second attempt by life flight medic was done with a 4 MAC blade and only the Eshman. The cords were seen with suction, but the Eshman wouldn't pass. Patient then assisted with BVM. Life flight attempted 5 more times with the glide scope. Being able to see the cords with suction while not being able to pass the bougie. Patient had a 4 eye gel placed. That's intubation attempts failed with good results. During this time, the patient's heart rate slowed. Is anybody surprised by that? And went into a PEA and CPR was started. While the patient was going into a bradyarrhythm, BP lowered. Life flight did give a dose of push epi, which didn't help. Patient given bilateral needle decompression, bilateral chest tubes by life flight with no improvement. 250 cc's of blood came out of the right chest tube, nothing out of the left. From 1750 until time of death, CPR was continued with patient in a PEA. Patient was given 2 doses of epi. Efforts were terminated after getting off the phone with online medical control at 1800. Well, so this is, we got a good description of everything that was given. He was given some, you know, got this, got that, got some epi, got some, now why the epi is beyond me. So, any rate, so did you, Preston, did you do this one? Yes. Yeah. There was a lot to talk about, but I skipped it. Yeah. Yeah. We don't have, there's a lot of things about this case that we kind of question, but we're not the life flight overseers. This was clearly a difficult case. Very sick, remote patient, bloody airway. Call is well documented though, which helps us get through this. Biggest issue from a clinical standpoint is the airway. So they did pre-oxygenate, paralyze the patient while in transit, which is a bit non-standard because, you know, I guess you're trying to get to the LZ, but it would have been better to probably make that attempt at the scene where you had a little bit more room to work. And then there were a large number of attempts on the airway altogether. I mean, they said, what, Life Flight had 5 attempts? That's a bunch. And then they placed the supraglottic airway. But what's the question in this case? This seems to be a logical place to try to do a crike. Trauma with blood coming out all over the place and inability to pass an ET tube from above, which kind of means to me like you've got something disrupted down there. So, not surprising that he arrested. No documentation of vital changes, vital sign changes, or pausing to reoxygenate during the attempts at intubation by Life Flight. So we think this was kind of a poster kid of someone who could benefit from a surgical airway. Much better than 7 attempts at an airway in a trauma patient. Now, the other thing which we didn't, which as Dr. Fedora alluded to, we didn't make any combination about whether we thought there was any point in doing traumatic cardiac arrest, CPR, and medications. You know, trauma, when traumas arrest in the field, they arrest in the field. You know, that's usually a reason to call them dead. So, we are attempting to make some, get some feedback from Life Flight on their management of this too. So we did the pediatric, did the pediatric ones. Let's see, what are my other adjustments? Other changes in the protocol just added to it. This is mostly informational. We added the phone list for Rainier Springs in the resource phone list. This is the Rainier Springs is now accepting volunteer mental health patients from EMS. But the patient has to be volunteer. It doesn't make any difference if they're on DSHS or not. It's not the question. It's whether they would be volunteer to go to an alternative mental health facility. Now your protocol we went over last October, November. It's in your protocol book. And it just follow the checklist as to what you need to know. And you say, well, we may not have time to sort out whether the patient really is qualified to go to an alternative facility. Hopefully, and this is what's happened so far, is that the adult mental health crisis team will have been at the place and evaluated the patient and say, this patient is a candidate for an alternative facility, alternative than the hospital. So just be aware of that. So you have to call Rainier Springs to make sure that they are taking patient at that particular moment. They may, for some reason, not be able to, and that patient fits their criteria. So the phone number is in there. Also, the new State of Washington scope of practice by certification level is in your protocols now. The one before was the previous version, which was accurate for the last 3 years, but now is not accurate. We added to the reference section your APGAR scoring table. We will add to the reference section your checklist for disabilities. And that's that. Okay, any questions, issues, ideas, thoughts? All right, thank you for coming. It's a good turnout.